Hello, everyone. Welcome. My name is Ali Fodi. I am a program officer with the primary care team here at NYHealth, and I'm so pleased to welcome you here to our conversation today. We have research hot off the presses in terms of medical assistants roles on primary care teams across New York State. And I'm going to get us started by setting the stage for this conversation. But first, I'll just do some administrative items. There's closed captioning available, so you can find ways to enable that functionality with a button at the bottom of your screen. We also will be recording today's session and we'll be sharing out an event recap shortly thereafter with the recording and slides and ways for you to stay connected. Lastly, I'll say we want this to be as participatory as possible, so please do pose your questions in the chat. I'll interject during our presentation to lift those up as I can and pose the questions to our presenters, and we'll save time at the end for Q&A. And also, please do introduce yourself, say hello to us and to fellow attendees. Please offer your comments. We really want to engage with you throughout this discussion and find ways to keep the conversation going after we share these initial findings. So what brings us here today? Medical assistants on primary care teams across New York State. We all know, we all believe here that medical assistants play critical roles on primary care teams. Yes, they perform essential functions like taking vital signs and preparing patients for exams, but more than that, they're an essential bridge between primary care providers and the patients that the care team serves in their ability to form trusting relationships as fellow community members, as neighbors. And we know that when MAs can take on more responsibilities on the care team, that everyone does better. Patients have improved health outcomes, nurses and doctors are less burnt out, the care and the care team's operation is more efficient. And now's a great time for that conversation because New York is currently considering a policy to be able to allow MAs to do more, to expand their role in the care team by allowing MAs to vaccinate under appropriate training and supervision. I'll say, and New York would be catching up in doing so, in that every other state in the country allows MAs to vaccinate, and you can understand why. In a doctor or nurse being pulled away to have to administer a vaccination and take them away from their complex care management. And so now's the time to talk about things like that and understand what the research has found in terms of unpacking findings of how primary care teams want to involve MAs in their care and see opportunities to grow, how they do now, the state of the workforce, how medical assistants are involved on care teams and what their experiences are, and how MAs get trained and placed in primary care across New York State. So we're here to hear from the experts on that. And shortly we'll turn it over to our presenters to share that research. But before I do, I have to pass the baton to partners who were invaluable in this research in being able to advise on the scope of this work, on the questions being asked, on executing this. And so I have the real pleasure of handing this over to Jasmine Vega-Pagrom, Executive Director of the New York Alliance for Careers in Healthcare.
Thank you, Allie. And thank you all for joining us here today. On behalf of the New York Alliance for Careers in Healthcare, the Healthcare Industry Partnership at the Mayor's Office of Talent and Workforce Development, I'm honored to welcome you to this important conversation about strengthening the medical assistant workforce in New York State. At NYACH, our mission is to build a more equitable and responsive and sustainable healthcare workforce. This public-private partnership was created to address the system-level challenges facing New York City's healthcare economy. So this project squarely aligns with that mission, offering actionable insights to inform policy, such as Ali suggested, guide investments, and elevate the role of MAs across the state. We've had the privilege of partnering with the New York Health Foundation and the Mullan Institute for Health and Workforce Equity at George Washington University on this research, which takes a deep and thoughtful look at how medical assistants are trained, utilized, and retained, especially within primary care. We would like to express our thanks to our incredible partners and our colleagues at the Department of Mental Health and Hygiene, NYC REACH, Chicanes, the Greater New York Hospital Association, and Northwell, whose support and participation made this study possible. And now we're excited to share those findings with you all today and explore what they mean for the future of our healthcare workforce. I would like to introduce our speakers and highlight their contributions to the work. First, we have Shauna Traeger, founder of SJT Consulting. NYACH sought her expertise to co-lead and facilitate the planning phase, and she also served as a key advisor to this multi-pronged project. She formerly led Workforce Initiative for Greater New York Hospital Association and served as one of my predecessors as the second executive director at NYACH. We will then hear from Cleese Erickson, Deputy Director of the Health Workforce Research Center at Fitzhugh Mullan Institute and Health Workforce Equity at George Washington University. She is the Principal Investigator on the MA research. She was formerly with the Association of Medical Colleges, and she is currently the leading researcher on emerging workforce issues like behavioral health workforce and team-based care. Additionally, we'll have Meg Zeman, research scientist, Mullan Institute. She has led the research's environmental scan of MA training opportunities and pipeline challenges in New York State, formerly at the Institute for Health and Research and Policy at the University of Illinois, Chicago. Her expertise in health workforce pipelines for professions such as direct care workers and peers is invaluable. And Leah Messelink, who is also on the call and will be facilitating questions in the chat. Thank you for all of your contributions as one of the lead researchers in this initiative. And with that, I would like to say I welcome you all. Just like Ali, please be interactive. Please, we have lots of facilitators and a lot of work that's gone into this, and we appreciate your time here. And I'll pass it on to Shauna. Thank you.
Great. Hi, everyone. Shauna Traeger. Thank you very much, Jasmine. Thank you, Ali. Great for setting the stage for today. I'm so excited to see so many participants on today's webinar and to share the findings that we've been working on for a while now on this medical assistant research. So I'm going to now set the stage for the initial planning work that I led with NYACH to really engage stakeholders in understanding what best type of research would benefit the field to advance both the roles of MAs as members of a workforce team, but also as primary care transforms how we want to think about MAs on care teams. So I am going to share my screen. Okay, hold on one second. Of course, I did this perfectly before. All right. So like I said, setting the stage for the medical assistant research project. I'm going to put it on slideshow. So I was very fortunate to be able to lead the planning phase for this work. What that really entailed was a really thoughtful process engaging stakeholders across New York State to understand the current landscape for medical assistants, what it looked like in terms of care team models, in terms of tasks and scope of practice, hiring and retention, training and education, what career pathways look like, and what folks felt like the most important qualitative and quantitative data might be to be collected to really advance, like I said, both the workforce development system to prepare MAs for this work, but also primary care practices and how they comprise their MA care teams. So in this process, we were fortunate to interview dozens of stakeholders. It really ranged across primary care practices themselves. The practices were small, one or two primary care practitioners with one medical assistant, up to big health hospital systems that had multiple ambulatory clinics across different sites. We also spoke with federally qualified health centers from downstate to upstate to Western New York. So there was a huge range, and it was very interesting in those landscape analysis to see the variance across primary care practices across the state and depending on setting. Also interviewed were trade associations, labor management partnerships, education from community colleges, from state university to vocational training programs, to the Department of Ed and career and technical education. So we engaged a whole host of different stakeholders in this landscape to really understand what the best type of research could be to advance the field. So the summary of the major themes that came up through these interviews, there seemed to be real general consensus that it would be very helpful to have some form of standardization and not necessarily standardization in like always a prescribed set, but at least some definition as to the range of scope and responsibilities of MA tasks. We know it's an unlicensed profession and that isn't fully all articulated. That might be helpful for educators to really know how to train MAs. Also, a lot of nurse administrators, practice administrators talked about how it'd be great to learn from how others are utilizing MAs and what the range of tasks are that particularly under certain population health initiatives. The second was that there would be a better, the field would benefit with a better understanding of the medical assistant training landscape. Where are their training programs? What the curriculum consists of? Do they lead to certifications? Do they lead in any type of national credential? And like, how do they do internships, and how can they form partnerships with those training providers? The third was that, as Ali spoke to, that I think is general agreement that everyone will benefit, patients and healthcare workers alike, if people are practicing at the top of their scope, particularly with nursing shortages and some burnout and a high demand for primary care services across the state. That efforts are needed to support this across occupations, but definitely included for MAs. And the last is that including injections and vaccinations as part of a scope was identified, particularly in some rural areas, as they're really needed to push in terms of including scope because of the nursing shortages and high patient volume. A lot of talk around how this was the strain on the system during COVID and the rollout of vaccinations, and how it worked well under some exclusions that were applied then. Certainly talked about flu season and fall and how that strained some of their patient, how it strained high patient volume and strained providers. So those were the major themes that emerged from the interviews. And we coalesced those with our partners that Jasmine spoke about who helped advise on this research construction, was what we could then recommend for the next phase of the research. It was great to have Cleese at this point come in from George Washington University and hear what was coming in from the field and inform the design and take it from there to the phase 2. So this is what was recommended. The first was the medical assistant scope of work, a real strong interest in understanding how primary care practices are currently utilizing medical assistants. And the recommended research method for that was a survey of primary care practices. The second was to better understand the training, supply, and workforce development system for preparing medical assistants. Given that MAs aren't required by any law or licensure requirement to have a specific training, it would be great to survey the landscape to understand what types of training is out there, what do the programs consist of, what funding opportunities are available to help support MAs to go through those programs. And so the research method for that was a qualitative landscape analysis, which Meg will speak to. And the third was hearing from medical assistants themselves and their perspectives on career growth opportunities. Where do they come from their careers? Where do they look to go? What did mobility look like? What do pathways look like? What do their training backgrounds entail? Are they trained on the job? Did they go to a program? Are they, is there job satisfaction? What makes a medical assistants stay in their position? What leads to high retention? What are the factors there? So for that, our recommended research method was convening focus groups of currently employed medical assistants. And I know that was a really important and exciting part of the research. And I know and I know Cleese will speak more to this, them also feeling part of this process too, and in a better understanding this field was critical in and of itself. And I know there was a lot of important insights gleaned from that research. So these were the 3 pillars essentially that came out of the planning phase and the landscape analysis and stakeholder engagement. The survey, the landscape analysis, and the focus groups were also informed by stakeholders. And so there was a very engaged process in every step of this. And that led to then the rollout of this training. Of this research. And with that, I'm going to now hand it over to my great partner in this work, Cleese Erickson, who, like I said, led with her team at George Washington University, the deployment, the final design and deployment of those 3 research methods.
Thank you, Shauna. I'm really pleased to be with you all today and share with you what we learned on this project. And it has been a great partnership, both with you, with NYACH, and with the New York Health Foundation, and all of the stakeholders who helped put this together. I just think this is such an important topic, and I really appreciate everyone's recognition of it as well, and learning what we found out about New York State and the use of MAs. I also want to thank my partners at the GW Mullan Institute, Leah Masselink, who was the primary leader of the focus groups, and an analyst on the survey. As many of you may have heard her present at the recent NYACH meeting, and then Meg Zeman, who will be presenting some of the findings later today. as we heard from Shauna, we had three main projects that we did as a part of the study. The first I'm going to talk about is the focus groups with medical assistants. We had the privilege of talking with 35 medical assistants from across the state, including 2 males, but it was mostly female. And a large number of them worked with the community health centers, others in physician practices. And I think it's important to note, many of them had been in the role for 8 years or longer. Average was 8 years among the people we spoke to. So this, and what really comes through in all of our conversations is their belief that this is a career, and often it was an entry way into health professions, including with aspirations to being nurses. What we found from this, which was the spirit of no research without us, about us without us, was really critical in informing our survey, which we fielded in November to March of 2025. We got 120 complete responses. It was a long survey, so I understand that 47 of them were partial, but it gave us really crucial information on what MAs are doing in primary care practices and interest in expanding their roles, among other topics. And you can see there, we also got a distribution of representation from community health centers and group practices and other settings. And they were also representative across the state. We did have a lot of responses from New York City itself. But so we appreciate everyone who helped us get that survey out and administer it. And then lastly, we did the environmental scan, and this involved interviews with key stakeholders, some of the people that Shauna spoke with, and then others. And we also combined that with the desk review to really get a clear understanding of what the state of New York is doing to invest in the MA training and where there are opportunities to enhance training. And what we're going to do for the rest of the presentation is weave all three of these components together to tell a story about current practice, barriers to MAs practicing and expanding their role, and then opportunities with in enhancing training to support MAs. So I thought I'd start off with hearing from MAs themselves about their role in patient care. And if you haven't listened to part 1 of this series, which was where Ali led some interviews with medical assistants, I encourage you to do so, because many of the same themes that I'll be talking about today came up in that call. But one of the things is that MAs really value their contribution on the care team. And some of the practices do as well, where one MA said that our clinic moved from a 1-to-1 MA to provider model, moved to one. And they did this for continuity of care. They recognized that this would be a chance for MAs to start learning the patient population and understanding them and building those relationships that are so important in healthcare, both with the MA and with the patient, and the MA with the provider. We also learned that sometimes this is from a MA working in a pediatric practice, that the parent may tell them something they might not feel comfortable telling the clinician. And so then that gives them the MA a chance to pull the provider aside and explain to them, well, this is what happened with mom. And then the provider can use that information to shape the rest of the interaction with the patient. And she went on to explain that the provider values this and her contribution, and she values being able to make that contribution. And then just one more example was that I think really speaks to the potential power of MAs when they can connect with the patients. And so this MA was talking about how grateful patients are to have someone to advocate for them, speak for them, be their voice, not just in terms of translation, but of language, but in translating what their unique circumstances are and how they can contribute. And so that I think is such an important component of MAs. And I thought it was really important that she said everyone deserves that kind of quality and treatment. And so we're here to talk about what MAs can do and how they're experiencing. And I think these quotes, I think, are emblematic of what's happening now and where we can go to enhance care across the field. We also heard some things they can't do, which we talked about a moment ago, about not being able to provide vaccines. And this is kind of perplexing to MAs who say, we can draw blood, we can do everything we can do all these things with needles, but we can't administer the vaccine. Yet 15 minutes away across the state in Pennsylvania, MAs are able to. And that efficiency-wise, it would just make the day go a lot smoother if they could do the vaccine versus waiting for an LPN or nurse to come in and do that for the provider. So it makes a lot of sense. So MAs want to do this, and I think, and we'll hear later that that primary care practices also are interested in expanding this role, including in FQHCs, as Ali noted. So We wanted to build on though and get be able to quantify what MAs are doing in their roles. And so we asked a series of questions. This is a really lengthy part of the survey, but so critical for understanding what MAs are doing and what they could be doing, what people are interested in expanding them. And so I'll walk you through this slide a little bit, and I'm going to make 3 points about it. That first, it's a proof of concept. MAs are being used in all of the tasks that we asked about, which are within their scope of practice. And that ranges from, and you'll see a fair number of them, 90%, 80 to 90% of the practices are doing these activities with MAs, including drawing blood. The blue portions of the bar represent where MAs are primarily responsible for it. The orange portion, solid orange portion, is where MAs are doing it alongside other team members like nurses, LPNs or RNs or care coordinators, depending on the task. And then the hash parts of the bar are where there's an opportunity to expand it. So we've got one, proof of concept MAs are able to do these things in primary care practices. Two, there's an opportunity maybe for greater efficiency in some of the practices that are having both MAs and other team members do it. Is there a way to redesign the care so it's more on the scope in the MA's role in those practices? Maybe that could introduce greater efficiency. And then the thing I'm particularly excited about is the strong interest in having MAs take on more of these tasks. And this includes population health activities. So here we can see this, that I was kind of pleasantly surprised to see that 60% of practices are engaging MAs in these roles. It's such an important part of care and an opportunity to have them be engaged in things like reviewing patient lists, extracting information from the EHRs. We heard a lot about that in our MA focus groups, where they would participate in morning huddles, have gone through to pull out information, help and contribute to visit planning discussions, because they can, as we heard from the MAs themselves in the quotes before, they can have a lot of input to share that will inform the care plan for the patients they're serving. And then they can be involved in identifying people due for chronic care management like HbA1c tests. And there's interest in expanding that role. They're also involved in patient education and coaching activities, but here we see a little bit less of that. And I think this is a real opportunity to enhance the MA role that will speak to their particular communication and connections with the communities they serve. And that can be like using motivational interviewing to help patients set goals. That's a really important part of helping patients adhere to their chronic disease management and other care needs that may be challenging for them. They can relay and reinforce patient education, like we heard from the MA, that they might not feel comfortable about raising some of these issues or asking questions of their physician themselves. So the MA can clarify that information. And they can also help patients with chronic disease goals even without motivational interviewing. So there's a lot of opportunity. And I'm glad to see a lot of interest among other practices in expanding these activities. We also asked about a whole host of others, and some of these are available in our report, which you can go online and get even more detail. We also asked on the survey, are you interested in MAs providing vaccines and injections if the law passes? And there was strong interest across the board, with 66%, 2 out of 3 primary care practices saying they would have MAs take on that role. And that there's also another 10% that said they might, they're not really sure yet at this point. And the interest is, as Ali alluded to, is even particularly stronger among FQHCs, with over 3 out of 4 FQHCs saying that they're going to have MAs take on this role if it becomes possible. And what I think is also important is that we asked, well, how would you train them if the law passes? And over 80% said they would train in-house with a nurse or physician. So I think that really speaks to the feasibility of bringing MAs into that role if they can do the training in-house. And there are many reasons to expand MA roles. And I think as we're all continuing to move towards the triple aim or the quadruple aim, if you include in provider satisfaction, there's opportunities for this to reduce burden on physicians, increase primary care practice productivity, improve patient outcomes and patient satisfaction, reduce burden on nursing staff. And all of these activities are potential benefits of expanding the MA role. So I think we want to, it just provides even more incentive to move in this direction, that primary care practices in New York recognize the potential benefits. And we asked them, well, what are some of the resources that you would need to expand roles? And we heard, and I was particularly pleased when we asked about training resources for physicians on expanded MA roles, that was one of the top things that they were asking for, because that, when physicians and nurse practitioners and physician assistants are going through their medical school or their health professional training, they aren't always trained adequately on team-based care. So and there's so many ways that you can enhance the role of integration with physicians and team-based care through educating the physicians themselves and not just putting it all on the MAs directly. And what I think is also interesting is that they asked for clear guidance on MA scope of practice, which I think this survey informs, because we are showing what MAs are doing already in the state. And this information can get out and help others see, like, oh, maybe I can have MAs do that in my practice as well. And what it also points to is the need for resources on best practices. And so this is a question that we have for you, be interesting at the end of when we have more room for a quick Q&A, is would you be interested in participating in learning collaboratives or want other resources to support enhancing the MA role in primary care? I think it's also interesting that getting nurse buy-in and physician buy-in was less of an issue, given that can sometimes be a barrier cited towards expanded MA roles, that the primary care practices themselves did not see that as essential to it. They really want the training and the funding to help make them adapt these programs. So now I'm going to turn to MAs and their perspectives on training and career ladders, because this is important for recruitment and retention, as you'll see from the MAs' voices themselves. And I did my internship here from medical school, and then I stayed here 8 years because I like to work here. I know everything. This is my second home. So there's a potential for people to really feel like their practices where they're working is a place where they can feel comfortable and like they're a part of the community. We also heard that some of us want to go back to school to advance their careers and do things, but it's really hard to do that without leaving their job or decreasing hours to go in the evenings, to go during the day. And then in the evening, it can be challenging because they have families and households to maintain. So this is a barrier that I think we're going to talk about some solutions through paid on the job training and how we can advance that, as you'll hear later from Meg Zeman. And when the MAs appreciate these investments, with the 4.5 years I've been at this particular practice, you start off as a patient care technician, and now I'm a lead patient care specialist. So you have a chance to move up here. So we want to make sure that when we're creating careers for MAs, that we've built in career ladders that will help them within their role, and then also expand to be able to go back out and get additional education to advance and have these things build on top of each other. And we also asked, well, do you have MAs that have grown? And we see that about 1/3 of the employers said MAs have started in other roles than the ones you might expect from front desk staff, patient service representatives, call centers. And then half of the practices said that MAs have advanced to other roles. And those are the ones you would also expect: LPNs, nurses, care coordinators, technicians. We heard a lot about that as well, including on our focus groups. But we don't know exactly the extent to how that's happening. But what we did ask about is what kind of financial support. And this is there's room for growth, I'll say, in this across the board. Both for helping MAs to transition to other careers and for existing staff to transition to MAs. Less than 20% of the practices that we interviewed provide direct tuition assistance, paid on the job training, et cetera, and it's even less than 10% for many of these activities. I will say that FQHCs were the ones that were most likely to have at least one practice or more doing any of these things. And as you might expect, solo practices were, it was harder for them to be able to offer these, but we did see some signs of that for MAs to transition to other careers. So it's nice to see that there are even some support for career advancement in the solo practices where it might be more challenging. In the midst of all this, we have heard that there are, from the primary care practices, they had recruitment and retention challenges, and there was a particular emphasis on retention compared to recruitment. But people, a little over 1/3 said they were satisfied with the available supply of qualified MAs in their area. And then less than half said they had access to a local pipeline of MA graduates. So it really speaks to the opportunity for investing in MA education and training to address some of these gaps that are out there. And so one of the opportunities that we asked about, because we heard about these on the focus groups, is BOCES is it's a vocational education investment that the state of New York makes outside of the New York City metropolitan area to help schools offer training programs in high school and also for secondary education. And their limited use in terms of MA training from the practices we spoke to, 12% at BOCES, 11% did paid on the job apprenticeship models. But you can see that over half of the practices are interested in learning more about these activities and how they can be, how training can be enhanced. And what's really nice is that these opportunities introduce health equity in the training, because in the high school model, there's no cost to the student. They come out with the potential for a job. And if it's linked with a career ladder, that's even more amazing. And secondly, paid on the job training models like state apprenticeship programs offer an opportunity for students to become trained and not take on education related debt, and do it during work hours when, as we heard from one of the earlier slides from the MA, these address the challenges of having to take time off from work or the cost, because so many of the MA jobs are very low paying. So the idea of missing out on any of your income to pursue more additional training or to take on debt is really challenging for these potential nurses and others who are starting out as MAs. So I think this is an area we also want to explore your interest in, is what can we do to better stand up and have greater participation in BOCES and apprenticeship models. And I'm going to turn it over to my colleague Meg Zeman now to walk through what she learned and identify opportunities around expanding MA training in the state of New York. And I'm going to advance slides for Meg as we go through.
Okay, thanks. And Meg, before you take things over, I do want to pop in to surface some questions, because I'm thrilled to say we've gotten a lot of great comments and questions. And so I'll pose a few in here that related to the findings, and then everyone, please know I'm seeing what's coming in and we'll incorporate that at the end also as we can. But first, just wanted to lift up a few things.
Sure.
One, thanks to you all who are providers yourselves or leaders in this space that have surfaced your own reactions to this idea of medical assistants being able to administer vaccines. It's great to see, first of all, that affirmation that there is that interest and that need among different types of primary care providers, particularly small practices. And there's a really important comment there around the need for, in vaccination and in other clinical tasks, the appropriate supervision and training to be able to do so. So wanted to first call that out. Thanks everyone for your comments there. There was one question that I also wanted to lift up at this moment around some of the predictors of why different organizations are having MAs take on certain elevated tasks relative to others. I will point folks to the survey itself to say that the survey does have a table breaking down what different types of primary care providers excel in terms of having MAs relay normal test results or doing patient education. Beyond that breakdown of certain community health centers or independent practice excel in these certain realms, team here, what can you offer in terms of your own impressions of what sets up organizations for success in allowing MAs to take on these more advanced roles on care teams?
I think one of the opportunities is if you have a larger primary care practice setting, then you can have the training investment on the site, so you can have someone who can serve as a mentor to people when they come on to take on the MA role. And that we heard a lot about that in our focus groups too, that people start off and they have help from someone as they even at all the settings they said they invested in training. And I think that's the critical opportunity to support MAs in this role. And then the other is, as I said before, and people were recognizing that the training element of physicians, I think the more you can do to have MAs train with the physicians that they're working in, that's another success factor. We didn't ask specifically about that on the call, but I do think that from other work I've done in the field is such an important and critical element.
Yeah, I'll just add, there was one specific question about, motivational interviewing is, you need training on that. And I think the ones that have included some health coaching aspect to the MA role, the one that I knew of specifically invested in a whole curriculum to train their MAs in those tasks. And it was a very thorough approach to doing internal on the job training to advance that skill set and then promote them to a new role. I think no one here thinks that there should be more and more tasks without like promotion or some sort of recognition and the additional responsibility. And in that case, the MA then moved to an MA2, an MA3, to a health coach, and commensurate with additional responsibilities. But it 100% required in that case that I'm thinking of an investment in education on the job.
Yeah, and I think it pays off, and you raise a really good point too. I'm glad you raised that, Shauna, about the pay scale increases, because we did ask about that, and for time we cut some of those slides, but there's not all the organizations are offering career ladders within the MA profession, and so I think that's another opportunity to really support MAs and giving them increasing responsibility. And some of the value of that to the employer is that when you see them in their initial role, even if they start out as a receptionist and move into the MA role or MA role into some of the other advanced careers, it gives you a chance to see who they are, how they are in the workplace, and get the workforce that you invest in the employees that you really see a lot of potential in, and make sure that they have the training, as Shauna pointed out, and the resources to provide those types of services. We did also hear on the focus groups that some of the practices were overstaffed, so sometimes they didn't really feel like they had a lot of time to do everything they wanted to. So I think thinking about staffing ratios in that case is an important one. And if you add MAs into roles like scribes, Meg and I have done some research that shows that it can lead to increased productivity and and also reduced provider burnout. So it's like a win-win, because that improves quality of care with the patient, because the provider can focus on the patient versus on the making sure everything gets entered into the medical record at the time. And then the provider has to spend less time in the evening documenting the caseload and can spend more time seeing patients. So it really is all these different activities that MAs can take on are really crucial support systems for the team as a whole.
Thank you so much. I'll just round us out to say what you lifted up in terms of, Shauna, the opportunities for training and the resources needed. Cleese, you're saying facilitating natural interactions between providers and MAs to facilitate the taking on expanded tasks make total sense. And I'll also call out one of our colleagues in the chat said something related to clinicians and just awareness raising around what providers can do on their care teams to allow MAs to take on expanded responsibilities. And I'll say that if that's of interest to folks on this call, that's what Cleese alluded to, is that we'd be interested to continue the conversation of, do primary care teams want to learn from one another around the innovative models that they're using in terms of having MAs take on expanded responsibilities. So watch out for a way for us to stay connected on that front. I'll ask and answer one last question, and then Meg, over to you. There was a particular question around the policy provision we've been talking about around MAs being able to administer vaccinations under appropriate training and supervision, around the timing and likelihood there. Around the timing, we'll just report on where the policy stands, which is that the New York State Senate has passed a bill to allow for such an expanded task and the permissibility of that task, and it's currently under consideration in the New York State Assembly in the final days of the legislative session. And the governor and the New York State Department of Health have similarly been supportive of such a policy, in the governor having introduced this type of provision to allow this to be a permissible task over the course of the past few years. Because we as NYHealth do not and cannot lobby, nor can any of our partners on this call, we don't know about the likelihood of passage, or not in direct conversation with these legislators, but we know about this movement across the country and an interest across policymakers in such a policy, and know that we have a lot to learn from other states there. And in our role, simply to shine a light on how are practices feeling about such a policy solution, and where do we think that we can go from here. So with that, Meg, would love to hear from you on the pipeline.
Absolutely. Thank you so much to the participants for their valuable comments so far, and to Ali for elevating them, and to Cleese for teeing me up nicely for this last portion of our presentation. I'm going to be wrapping things up by presenting just some select findings from that statewide landscape of MA training programs and models in New York. I'm not going to go into detail on all of the findings, but I believe we will be popping the link to that report into the chat. You can read much more. And happy to answer any follow-up questions that you might have. As part of our scan of the MA training landscape in New York, we did identify several MA training models that we believe show promise, both for their responsiveness to MA as well as employer needs. So some of these models include high school programs for career readiness in the health sciences, including medical assistance. So Cleese mentioned BOCES, which stands for Boards of Cooperative Educational Services, which is a program providing regionally targeted educational and vocational training services for school districts across the state, both for high schoolers and adult learners. There are also high schools that provide career readiness training, providing high school students with employable skills and certifications that then enable them to enter the health workforce immediately upon graduation, providing them with valuable skills in the medical field that they can then further leverage for professional advancement. And many examples of high schools that include an MA training pathway within them. There are also plenty of examples of employer-sponsored medical assistant training programs. So I'm just going to point out one by way of example. Northwell Health System, for example, as an employee benefit and in partnership with the city colleges of New York, offers full tuition reimbursement to eligible employees to go back and get their MA certification. Many of you on the call may be familiar with the Career Pathways Training, or CPT program. Now, this is a new program in the state that was authorized under an 1115 demonstration waiver as part of New York, the New York Health Equity Reform Waiver Amendment through the state's Medicaid program. It was designed to address workforce shortages, both through career advancement and recruitment pipelines. It is open to 13 professional titles, and that does include medical assistants, and is administered regionally through 3 workforce investment organizations, or WIOs. It provides eligible participants with tuition and fee assistance to get their certification and training, as well as case management and tutoring and mentorship opportunities in exchange for a 3-year service obligation in a facility that serves primarily Medicaid and the uninsured. And lastly, of course, we have apprenticeship models, and they are an example of a grow your own, earn while you learn model. Cleese talked a little bit about survey findings that reflected interest on the part of employers. And I am going to spend just a little bit more time in the next couple of slides talking through the apprenticeship model in particular. But before we move on, I do just want to point out 3 characteristics that all of these training models have in common, and that I think might be helpful to have in mind as we transition to the more interactive portion of today's webinar. So first, from an equity perspective, all of these training models address unique challenges that are faced by the prospective MA workforce. So that includes financial barriers to education and training. Just for context, as part of our national scan, we found that tuition costs for MA training range from $3,000 to $4,000 on the low end, all the way up to $10,000 to $12,000 at private for-profit colleges in New York State. So all of these programs represented on this slide provide subsidies or full tuition reimbursement for those costs. These models also meet workers where they're at by integrating training into the workplace or into the education space. They also all involve cross-sector partnerships between stakeholders from education, industry, and government, and all were created and designed to be responsive to employer demands and needs, both in terms of bolstering the supply of workers, but also to ensuring the fitness of the skills and competencies of the medical assistance workforce. Next slide, please. And as I mentioned, I do want to spend just a little bit of time spotlighting apprenticeships as one important spoke on the wheel in MA workforce development in New York State. So apprenticeships, as many of you probably know, are structured hands-on training models that allow apprentices to earn a wage while they learn under the supervision of a preceptor. Formal apprenticeship can be registered either at the state level or at the federal level, and they provide many benefits in the context of medical assisting. So, for example, we've already talked about the fact that these are earn while you learn model. They remove some of the financial barriers for trainees, as well as the opportunity cost that comes along with leaving the work site to go and get that clinical training. Um, this enables employers to recruit from their own communities and grow their own workforce to be a workforce that reflects the communities served. There's also the aspect of the potential for institutional knowledge transfer and the opportunity to shape and tailor the training of your MA workforce to reflect the training culture, environment, and mission of the employer organization. Also promotes retention of employees, and in some cases provides wraparound supports to meet the social needs of MA trainees, as well as their educational needs. Um, However, apprenticeships are a commitment, as conveyed by the quote on this slide. There are certainly challenges to standing up and maintaining apprenticeships that have led to low uptake of the model in New York State. There is only one registered MA apprenticeship program with the state of New York. Many of the challenges that we heard from our key informant interviews are listed in this downward facing arrow and kind of boil down to just the amount of work that it takes to stand up and maintain one of these programs. And while I want to say that there is no single program or model that alone will drive the development of a robust MA workforce to meet the needs of the New York healthcare system, apprenticeships, as I said, do represent one spoke on that wheel that we think deserve just a little bit more discussion, particularly because we do have a strong proof of concept for an MA apprenticeship, as well as supporting infrastructure that exist through Chicanes and the SUNY apprenticeship program. So if we can move on to the next slide, please. As I mentioned, there is just one MA apprenticeship program that is registered in the state of New York, and that is the apprenticeship program through Chicanes, or the Community Health Center Association of New York State. And thus, we think that it's likely to have valuable insights on lessons learned that, if part of a larger discussion, could help in efforts to scale and expand apprenticeships and identify potential solutions and needed resources to be able to address some of the challenges that were mentioned on the previous slides in this presentation. So we can ask ourselves, how might the Chicanes experience, or even that of apprenticeship sponsors for other health professions programs, be harnessed to strengthen medical assistant workforce development in the state? And similarly, how might existing state investments in workforce development be leveraged for medical assisting? So I draw your attention to that next arrow down, which highlights the SUNY State of New York apprenticeship program. This is a program that is sponsored by the Department of Labor. The healthcare arm is administered through SUNY Schenectady. It has not yet been tapped as a resource to provide any medical assistant apprenticeships, but the potential is certainly there because MAs are an eligible profession under it. But it does beg the question as to whether money is being left on the table that could be used to increase the supply of MAs in New York through enhanced training opportunities, particularly training opportunities that would not require trainees to go into debt to get their certification. And I do just want to point out that the apprenticeship program does offer resources and services to facilitate the development of apprenticeship programs. This includes navigators and a business development team to help employers with the startup process. Though what could really result in momentum for medical assistant apprenticeships would be the designation of a group sponsor. This is something that we heard through the interviews we conducted. A group sponsor might be an entity like a health system or association that could provide collective support for ongoing maintenance, monitoring, and administration of MA apprenticeships across the state. A group sponsorship is the hub for apprenticeships in New York and other industries, but it doesn't yet exist for healthcare professions like medical assisting. Next slide. And I just wanted to, in my last couple minutes, reiterate a theme that came up through the focus groups, that regardless of the pathway medical assistants take to enter the field, medical assisting can serve as an optimal stepping stone to other health careers and licenses, providing an opportunity for career advancement and upward mobility for workers, as demonstrated through this career map. We see other advancement opportunities in the health professions through nursing, clinical research coordinator, phlebotomy. These career advancement opportunities not only act as a powerful recruitment and retention tool for employers, but also provide current and prospective MAs, who are primarily women, with women of color overrepresented, with pathways to promotions and higher wages. And if we could extend this map out to the left, you'd also see that medical assisting itself can be a stepping stone from roles such as clerical work and administrative assistance in the employer space. Next slide, please. So I'll just end by saying that the medical assistant education and training landscape, we believe, is ripe for mutually beneficial workforce development partnerships and collaborations, as evidenced by some of the program models that I just briefly shared with you today. Yet to fully realize the potential of these partnerships, improved cross-sector coordination and awareness of opportunity is needed. This is going to require bringing together multiple stakeholders to identify and build upon their collective and individual contributions to and benefits from MA workforce development initiatives and investments. So a collaborative, coordinated, cross-sector partnership is what is needed to benefit workers, educational institutions, employers, and the health systems, ultimately to create a stronger, more sustainable MA workforce. And we have the perfect platform today just to start this discussion. I was really pleased to see so many of these stakeholder groups represented on this slide in attendance on today's call, and look forward to the few minutes we have for remaining discussion and Q&A. Thanks for your time.
Thanks so much, Meg. And we have a lot of great traffic here in the chat, so I'll lift up one question around MAs that can and want to stay in the role versus MAs that can excel into other professions. First, just before I get into the meat of the question, I just want to acknowledge there's a really rich discussion in the chat around the state of the MA workforce. Some folks described it as precarious in terms of the financial stressors of being in a low-wage job as an MA. Folks described it as impermanent, whether as a good thing to be able to catapult into other roles or as a bad thing in terms of the lack of stability they're in. So I just want to say that there's a lot of great discussion around what's needed to support MAs in and beyond the role. There was a question, well, in the track, there is this rich conversation around MA's advancement, and I would put a pin in that and say, we want this to just begin the conversation around how we can support MA career advancement and what training opportunities are needed to propel that. A question in the chat was around MAs that want to and do stay in their role as MAs. Clece, you at the top talked about MAs feeling like their role is a profession and a calling. And can you dig deeper into that and then also answer the question of what did you find in terms of facilitators of MA staying in the role and barriers to their doing so?
Sure. Thanks, Allie. And I think those are all the comments that you've raised, I think are really important to keep in mind. These are low-wage jobs. Not all of them are ones that are easy for the worker to stay in. We heard from our focus groups of some people saying they had to choose between paying rent or paying for the health insurance that was offered, and they couldn't afford the health insurance and are relying on the provider they work with for care or dental care from other providers. So it's not every job is created equal, but there is an opportunity within the profession to have career ladders because the MAs themselves, and again, I'll put in a plug for Allie's webinar because you can hear them speak about it so eloquently. They really see like they are a patient's voice and representative. That one quote that I elevated was not the only person who said anything about that. They are often from the communities they serve. They understand their unique needs, and they want to be there for their patients. They talked about connecting them with social services. They talked about being a translator. They talked about being a sympathetic ear. Particularly, I think this was also the woman who was in the pediatric practice, where, when patients came in with complex child health issues, they were there to listen and lend an ear. They are the patient's advocates and champions and see this as a calling. And so to help them advance in their career, I think what also came through in the focus groups was interest in ongoing education and professional education. They want to do well in these jobs. They want to have the answers and be the resources for their patients and not have to say, I don't know, let me check back with you. And a point I wanted to raise earlier in the question you asked about what can be done to help patients with taking on some of the more complex roles that they can be involved in. I think one point that I was reminded of in Meg's presentation is that you can coordinate with the MA training programs in your area and say, these are the skills I need, and help them build that curriculum, and then also serve as an internship site so that they can then come and be trained in your setting. So they are sure to have the skills and training and resources that are specifically needed for your population.
Thank you so much.
Sure.
And let me say a thank you again to all of our participants. Folks were responding to one another and surfacing thoughts, posing questions, posing your own experience as MAs and MA supervisors. And the hallmark of a good conversation is that more came up than we could answer in the moment. And so the first thing that I wanted to say to you all is that we want this to be the beginning of the conversation and not the end. And I mean these talented workforce development leaders, researchers, us at NYHealth and NYACH that are committed to MA advancement. And we want to hear from you about ways that we can do so. And so in the chat shortly, you'll see we have a link to a very quick survey. Just say, who are you? Do you want to stay connected with us? On what topics? Apprenticeships, providers learning from one another about how they can transform their care teams to allow MAs to play larger roles. And how do you want to do that? Would you like to get a briefing from us? Would you like to have a small group interactive discussion? Cleese alluded to a learning collaborative for providers to come together. So please do fill that out. We're really eager to keep this conversation going and not just talk about findings, but about translating those to action. So I will first wrap us up by saying, on behalf of NYHealth and the New York Alliance for Careers in Healthcare and Jasmine, we want to thank you all for coming and thank you for participating in this, for learning and then also participating in this conversation. We think there's opportunities to keep this going. And as immediate next steps, in addition to you all staying in contact with us, we'll be sending this recap out so you can go back to the findings yourselves. You can share it with your colleagues, spread the word. And we encourage you in general, just stay connected with NYHealth, with NYACH, with the Mullan Institute team. And thanks for joining us this afternoon.
Thank you, Allie. This has been really a fun conversation. I hope that we will have continued participation and engagement from those of you on the call.
Thanks, everyone.
Yes.
Take care.
Thank you,
Thank you.
everyone.
Thank you.
Bye. Thank you.